this video, we are going to describe how to perform a hand-sewn microanastomosis in a rat model. The first step in learning microsurgery is becoming familiar with your equipment, the instruments, and the operating microscope. Practice using the controls of the microscope. The more automatic it becomes, the easier it will be to perform the more challenging tasks, and the less fatigue you will suffer. Learn how to adjust the optics. It's crucial that you and your assistant are both in focus, and a simple adjustment can ensure this. First, if you're not going to wear glasses, dial your refraction into the optics. If you are going to wear glasses, rubber bumpers on the optics can allow your glasses to be at the right distance from the lens. Once you have the focus set, have your assistant set their optics so they're also in focus. On a good microscope, minimal adjustment between the two operators is necessary. Additionally, the focus and zoom controls should become familiar. In this case, we have a foot pedal, and so it should be within an easy reach of your foot to be able to feel it at all times. If your microscope has hand controls, you should know where the buttons are. One should not have to look outside of the field of view in order to operate the zoom and focus controls. The next step is positioning. Once you have set up the anastomosis under the microscope, then you need to ensure that you are comfortable and that the procedure will be ergonomic. You should be sitting directly on top of the chair. You should not be leaning into the microscope. If you lean too much, your back will fatigue and your chair may slide away. Constantly repositioning and keeping tension in your muscles to stay in position leads to fatigue. This can affect the performance under the microscope and can make the procedure much more arduous. So this is a beautifully prepared artery. There's been some time here for some of the antispasmodic agents to take effect. It's nice and plump. And we're going to apply our clamp now. So the clamp should be applied just in the tips of the clamp. It's a good idea to pull the artery into the clamps so that it's not under a lot of tension, because as you see when I cut that, the ends will tend to separate. And we want to have as much room between the two clamps as possible. This little branch shouldn't be a problem for us, so I'm going to cut it over here. You can see how the two ends separate. And if it's under more tension than that, they even separate more. So we can push the two together a little bit. So as we irrigate the blood out with heparinized saline, and so we often do a little dilatation of the end of the vessel. And this should be very gentle, just a little spreading with the dilator inside the lumen. It's really just to break any vasospasm. It shouldn't be used to try to stretch the vessel beyond what it normally would have as a diameter. But just to stretch the muscle back to its normal size. So once we have our needle, we want to position it in the needle driver so that it's about a third of the way in the driver and about 2/3 coming out. It should be toward the end of the needle driver. Now another word about arm positioning. People tend to operate with their arms out like this, is what we're used to when we do macrosurgery, but that doesn't align the needle with the vessel very well. And so one needs to change one's habits, put one's elbows in to the body, and maybe even the wrists closer together so that the needle aligns with the axis of the vessel. So one needs to get used to the idea that your elbows are going to be in close to your sides in order to achieve this transverse orientation of the needle so it's going across the field of view. Now of course, in practice in the operating room, the vessels will not necessarily be in this transverse plane, and one will need to move one's body around or one's arms around in different positions in order to achieve the needle being parallel with the axis of the artery. Once we have our needle positioned properly in the needle holder, then it's time to place our first stitch. Our first two stitches are going to be at opposite ends of the artery, the 180 sutures. So one will be on this side over here, and the other over there. Now, it's hard to put a needle in there because the needle really just goes down like this. So The method of doing this first stitch involves using your needle and dilator in combination to gently pass the artery over the ends of the dilator, and then spear the artery on the side where one is going to place the stitch. Flip that artery over. See how that's rotating over the dilator and then pushing it through. The next step is to flip the artery over the needle like this. You see that I'm not even moving the needle, I was just flipping the artery. And then immediately repositioning the needle in the needle driver. So once one gets a little opening in the end of the artery here, put the needle through on the side. The next step is to flip the needle driver over so that the ends are pointing downward, and then one can gently pull the needle through the artery. The manner of pulling the stitch through then is just to pull to the right. I'm just keeping it in my needle driver and I'm moving all the way to the right. I'm not looking outside the field, I'm looking at the field to see when my tail has come to the right length. Now, if I just dropped the needle now, there's a good chance it would be stuck to my needle driver, and I would just pull this whole stitch right out as soon as I move my right hand. So instead of doing, I'm going to stabilize this stitch here by holding it there, and now whatever I do with my needle and my right hand will not affect the outcome of the stitch that I've already placed. Now I'm going to open the needle driver, but there, as I said, there's a good chance that the needle is stuck to that by blood or magnetism. And so in order to detach the needle from that suture, I'm going to keep my hand moving to the right, and that's going to ensure that the needle has now dropped off. And so when I bring my needle driver back into the field, there's no needle on it. On the way back in, I'm going to flip my needle driver over back to its original position so that the dilator and the needle driver are facing each other, and I'm going to grab the stitch so that I have a loop of suture material coming out of the needle driver, going up to the lens, and then down to the vessel this way. This allows for the easy wrapping of the stitch around the dilator, the tail of the stitch that way. Then I wrap it the opposite direction, pull it. I do not believe that you need to have square knots across your hands. You don't need to drop the square knot. 3 knots are fine, and we finished our tie. This should be cut fairly short because the tail can get in the way of the next stitch. I like to leave the other tail long. This can serve as a handle in case we have to place some sutures in between ones that we've already placed. Now, the other reason for having the suture in the needle driver this way during the tying is that it makes it easy to reposition the needle for the next stitch. So I grab it with my forceps or my dilator, I open the jaws of the needle driver, and I simply pull the thread through the needle driver until the needle appears in the jaws. It's a long stitch, sometimes that takes a long time. Okay, there it is. So it's inside my needle driver. Now I supinate my fingers or my hand, and I bring the needle down toward the tip of the needle driver. I want it to be sticking out the bottom. That's how I'm going to manipulate it. So there it is. I just moved it around a little bit each time in order to get it sticking out the bottom. I move it down to the end of the needle driver, and I don't want to take it out of the confines of this needle driver because there's a good chance that it's going to fly somewhere and you'll never find it again. So here's a crucial step, flipping the needle over so that it's in the correct orientation to place the next suture. I've seen some people put the needle on the tissues and try to spin it around. It looks awkward. It can bend the needle. I'm going to show you a very simple maneuver that automatically flips it over. This involves several maneuvers performed at the same time. One is sliding the dilator towards the tip of the needle like this with gentle pressure on the needle. The other is that I will be pushing the needle driver downward away from the field of view, and I'm going to open my grip on the needle very slightly as I do those two things. So here we go. So I'm going to slide this way, push down, and open the grip at the same time, and you're going to see that it just flips over into the correct orientation. Now the next step involves reorienting the suture material, which now is coming across our field of view to my left. So we want to have this trailing the needle. We don't want it to get in our way. And so I'm going to take my hand, I'm going to move my hand all the way to the right. I'm still looking in the field of view, and then I bring the needle back in the field of view, and my suture material now is trailing from the other side. So it's time to place my second 180, which is done the same way the first one was done. I put my dilators inside the lumen. I flip that over the dilators, and I insert the needle. Gently flip the vessel over the needle, and then I re-grab it and reposition it all in one maneuver. So the next step is to grab the adventitia on the other side, open the vessel, pass the needle through, and then drop it. Flip the needle driver over as we did before, grab the end of the needle, pull it through, and then pull to the right. Just keep pulling to the right, not hand over hand, until we get a tail that's the right length for us. Stabilize the suture, release the needle driver, keep moving my hand to the right, and then come back in. As I come back in, I flip the needle driver over so it's oriented correctly for the stitch. Dilator, surgeon's knot, pull. A little detail about pulling down: if one pulls too hard with the left hand, the tail becomes too long, and we lose the loop here, and then one has to readjust this. I purposely left the loop the right length, and I don't want to have to pull it through again. And so by paying attention to how I'm pulling that knot down, I don't need to add any extra steps. Alright, now I pull the suture material through the needle driver until the needle comes in. Supinate the needle driver. Do my flip maneuver, which involves loosening, sliding, and a little downward pressure with the needle driver. Then I move to the right to have the suture material trail, and I'm back in business. We're going to fill in the gaps between these two 180s. Another detail about the needle: there is a tendency to want to place the needle perpendicular to the vessel by sticking it down this way. And then the novice will want to have that needle come out the vessel this way, and instead of twisting their fingers to do that, they just keep it pushing down and keep pushing that way. That's going to bend your needle. Instead, I recommend using your dilators to lift up the vessel wall, and my needle is mostly horizontal. I place it where I want it to pierce the vessel, and I push down a little bit so that it goes inside, but it's mostly horizontal. Now this is going to be done in one throw. I pick up the adventitia on the other side and I just place it over the end of the needle. This way I'm certain that I haven't had a back wall stitch. I just gently push it through, flip my needle driver over, grab the needle, pull a little bit to the left first, and then I pull to the right until the tail is the right length. Stabilize it, drop my needle, come back in, flip the needle driver over, grab the suture material. I don't need surgeon's knots anymore. I can do a single throw. Okay, the rest is just repetition. Reposition our needle again. Supination, repositioning, flip, all in one maneuver. The trail maneuver, and we're going to put another one in between these two. Again, a little spread, needle mostly horizontal, push it through. Another thing that one tends to do is when one's removing the dilator from this small opening, one's so excited that you got the needle in, you just let this spread out maximally, and it can tear the vessel in the worst case scenario, but in the best case scenario it's probably causing some intimal damage. Again, this is going to be in one throw. Lift the vessel over the end, then just gently push it in. The motions that I'm making are tiny. One repeats these maneuvers over and over again, one can get into a situation where it becomes routine, and the speed with which you can do a microanastomosis is much improved, and therefore your fatigue at the end of the case is much better. I don't think there's enough space for me to intubate, so I'm just going to pass it gently, pretty much under direct vision. Okay, we finished our front wall. We're going to flip the clamp over. Step will be to check to make sure we haven't created a back wall suture. A little heparinized saline is good. And then we can look inside. It's nice and clean, no back wall. Now we're going to finish the back wall sutures. I like to sew towards myself. I'm going to start over on the far side. Same idea, just drape the vessel over the end of the needle. After one places the needle through the vessel, one still has the flexibility of where to tie the knot down. So if you're not too happy, or you're not perfectly happy with where that needle punctured the vessel, close a gap somewhere else. You have some options about where that gets tied down, either closer to the last one or farther away. So that I'd have a little more room here to place our last suture. I'll also illustrate another method of grabbing the needle. Let's say it comes out of your needle driver and you're having trouble grabbing it. So here's another technique that I learned from laparoscopy. One can hold on to the suture material like this and then pivot the needle either on the tissue or the background. Grab the needle with the needle driver this way. That's another method that one can use to grab the needle. Okay, so I'm going to put my last suture in. Clamp back to the other side for the removal. Now, we remove it, the distal one first, then the proximal one. It's typical to see a little bit of bleeding. So we'll do our strip test now, which pretty conclusively determines patency of the anastomosis. The way this is done is one places a forceps on the vessel, distal to the anastomosis, strip the blood out of it in the distal direction, and then release the proximal forceps. And if it fills rapidly, there is no question that the anastomosis is patent. That's the only way that can happen.
That's perfect. That's great.
I think it's really important to perform all the steps we've outlined today in the same order and the same way each time you throw a stitch. Once this technique becomes routine and microsuturing becomes easy in the lab, then transferring that technique to the more difficult clinical situation will be easier. When positioning is not ideal, when blood is obscuring your view, when the needle is sticking to everything because of blood, or when the field of view is moving because of breathing, then you can fall back on these routine maneuvers that you've already perfected, and it will be possible to perform even the most challenging microanastomosis.